Thank you so much for your invitation and for making this go ahead in spite of a global pandemic. I much appreciate being here, and I've certainly learned a lot so far during the presentation. I'm going to talk just a little bit about contact lens use for neurotrophic keratopathy, and one could really argue that they're the greatest idea that you could possibly imagine, or you shouldn't consider them at all. So hopefully we'll come to some sort of a middle ground during the next few minutes. I have no disclosures. We're not going to talk about any off-label use. Learning objectives here would be to understand both potential risks and benefits of contact lens wear for patients with neurotrophic keratopathy. And then we're going to take a look at some cases in which contact lenses were used to manage this condition. So bandage contact lenses are certainly a possibility. The therapeutic benefits would include complete corneal coverage along with preservation of visual function. However, full-time use or continuous use of soft bandage contact lenses has been associated with an increased risk of microbial keratitis. So if you are going to use a soft bandage contact lens, take care that you're watching carefully. Also, we've got a piece of plastic that is rubbing against a diseased and fragile cornea every time a patient blinks with a bandaged soft contact lens. So may need to take a little bit of care if you're going to use a bandaged soft contact lens. Scleral lenses are certainly a possibility as well, and I'm going to spend the majority of my presentation discussing this. So scleral lenses certainly provide excellent corneal protection. You'll see here this is a diagram of a scleral lens on the eye. It lands on the conjunctival tissue beyond the limbus and traps a fluid reservoir behind the lens and in front of the cornea. So if a scleral lens is fit properly, you get complete corneal and limbal coverage or clearance and landing out beyond the cornea. So you could certainly see where you remove the possibility of shear forces from the blink, damaging this fragile cornea, and you're also bathing that cornea continuously in some type of fluid. So therapeutic benefits of scleral lenses include improvements in visual function. One of the earlier presenters talked a little bit about the fact that neurotrophic keratopathy can in fact cause some visual degradation. Scleral lenses provide a new front surface for the optical properties of the eye, and that surface is smoother than a cornea with an epithelial defect. The study by Ling talked about a few different types of non-healing epithelial defects. 3 out of the 4 patients who had neurotrophic keratopathy achieved visual acuity of 20/70 or better. Here in the United States, that means that they can drive during the day, and so that is a landmark visual acuity. We did a retrospective study of our patients at Mayo who had been fit with scleral lenses for the management of ocular surface disease back in 2014. We reviewed approximately 115 patients. 20 eyes among those patients had neurotrophic keratopathy, and logMAR visual acuity improved from 0.75 to 0.30, which was statistically significant for this condition. So you can get some immediate visual improvement. Also, as the cornea heals, that visual improvement can be observed even when the patient isn't wearing their lens. So what are some of the issues related to scleral lens wear? Well, there's a relatively high burden of care. The application and removal process of the scleral lens requires that the patient be in a face-down position. It requires somewhat steady hands, although there are ways around that if you can hold the lens in a stand. But a patient does need some level of dexterity in order to be able to place the lens onto the eye. Relatively high complexity of care as well is part of scleral lens therapy, whereas a patient wearing a bandage contact lens may need to simply put that lens in once and leave it in for a given period of time. Scleral lens wearer is going to need to remove and replace that lens and disinfect it throughout the course of the day. As the first speaker mentioned, some patients who need to wear lenses continuously have 2 pairs of lenses, 1 pair for daytime and the other pair for nighttime, and so there's some extra cost and extra bother involved with that. We're always concerned about microbial keratitis with any type of contact lens wear, but as of yet there have not been any epidemiological studies that have defined the incidence of microbial keratitis in neurotrophic keratitis or neurotrophic keratopathy or in any other indication for that matter. A single case study by Zimmerman did describe the development of microbial keratitis in a patient with neurotrophic keratopathy due in part to the fact that the patient was storing the lens in saline rather than in a disinfectant solution during a break during the course of a wearing day. So if you are going to prescribe scleral lenses, you are going to have to be careful about making sure that patients know how to clean and disinfect the lenses safely. So decided to take a look at our experience a couple of years ago, and we did a retrospective review of patients with neurotrophic keratopathy who were fit with scleral lenses from June of 2006 through June of 2016. Our outcome measures included visual acuity, corneal epithelial integrity, along with monitoring for corneal scarring, neovascularization, and any other sort of complications that we may not have identified at the beginning of the study. We identified 42 patients who had that condition and were fit with scleral lenses during that time period, representing 47 eyes. 14 of these patients were male, 28 were female. Mean age was late 50s, but the range was 23 to 85 years. Roughly half of the patients were fit with the right eye only, half were fit with the left eye only. Bilateral fits were accomplished in 5 patients, and we had a mean duration of follow-up right around 2 years, with a range from 1 to 98 months. So given the fact that this was a retrospective study, unfortunately, we didn't always have the most pristine documentation of the condition of the corneal epithelium prior to and following scleral lens wear. So we didn't have that pre- and post-corneal evaluation available for 11 eyes. Of the eyes that we did have that information for, epitheliopathy was present in 24 eyes at the initiation of the fitting process, and complete resolution was noted in 22 out of these 24 eyes within the course of the first month of scleral lens wear. Epitheliopathy improved but didn't completely resolve in the remaining 2 eyes. We had a number of eyes that had problems and were fit with scleral lenses for ongoing protection. None of these patients developed epitheliopathy during the course of the follow-up period. In this particular group of patients, which is very small, we did not see any new neovascularization, no new corneal scars, and we had no cases of microbial keratitis. So visual acuity was measured using a projected Snellen chart for all patients, and then the Snellen values were converted to logMAR equivalents for the purposes of statistical analysis. Very much like our retrospective review of all patients who were fit with lenses for ocular surface disease, pre-lens acuity was 0.69, and visual acuity at the most recent follow-up was 0.35, and that difference was statistically significant. So after completing that study, we got pretty confident in our ability to manage patients with neurotrophic keratopathy with scleral lenses. However, this could have been beginner's luck, because one of the patients that I saw in 2017 was an 84-year-old Caucasian female who came through the clinic seeing our facial reanimation team. She had a history of squamous cell carcinoma with perineural invasion of the left temple that had been surgically excised and treated with radiation as well. She was reporting some blurred vision in her left eye. At initial presentation, she was about 2,500, and there was some mild epitheliopathy present, and this is what the eye looked like. So she had a limited blink function, she had limited corneal sensation, but just a little bit of epithelial irregularity and a bit of staining. Unfortunately, I didn't get a photo of that. So in my mind, this is a perfect time to do scleral lenses because we can protect and preserve corneal function. And so we fit her with lenses, dispensed the lens on August 16th of 2017. Visual acuity was 20/30. We were all very happy about this. Patient returned home, was to follow with her local provider, which unfortunately she did not do. She returned to us 2 months later looking like that. Huge epithelial defect and hypopyon. We determined that this was not an infective ulcer, but rather just a neurotrophic ulcer. The suspicion is that, much as Jennifer talked about the possibility of damaging corneal epithelium with a drop, she may have developed an epithelial defect due to improper application technique for her scleral lens that just then grew. So she ended up with a tarsorrhaphy and did eventually heal, but did not maintain good vision in that eye. I learned my lesson and started following these patients much more carefully. I did not trust them to follow with their local providers. I insisted that they stay here until we saw full healing of the epithelial defect. My next patient, or another patient that I've seen pretty recently, was a 53-year-old Caucasian male with brittle diabetes. He was referred to me for a scleral lens evaluation for management of recurrent corneal defects. Initial visual acuity was about 2100 in the right eye, 2400 in the left eye. Initial corneal evaluation, he had some inferior epitheliopathy in the right eye, but a frank defect in the left eye. And so this is his right eye, left eye at presentation. So dispensed a lens for the left eye first, followed by the right eye about a month later, and he was thrilled with his vision, which had improved. Approximately 6 weeks after that lens was dispensed for the left eye, however, he developed another epithelial defect in the left eye despite scleral lens wear. So we became rather nervous about that. He underwent a temporary tarsorrhaphy with the idea that he would eventually undergo a permanent tarsorrhaphy in that eye. The physician who was attending him at the time decided that scleral lens treatment had failed. However, the patient was having none of this permanent tarsorrhaphy discussion and wanted to go back to scleral lens wear. With him, too, I suspected that lack of corneal innervation was playing a role in his inability to put the lens on without damaging the cornea. So I put a soft bandage lens on the eye first and applied the scleral lens over the bandage eye for the first several weeks until he could demonstrate reliable, safe technique for lens application, and then we discontinued bandage contact lens wear. He is continuing to wear the scleral lens successfully, and we are following him very carefully. So there are a couple of post-surgical challenges with scleral lenses. If a patient has undergone a tarsorrhaphy, we may not have enough room to get the lens on the front surface of the eye. If a patient has undergone corneal neurotization, we could end up with something that looks like this. This is a patient, you can see way at the right edge of the screen, that elevation that's directly adjacent to the cornea. You can see the scleral lens over top of the cornea here. Unfortunately, this patient had both corneal irregularity, which could have benefited from the use of a rigid gas permeable lens, and neurotrophic keratopathy, and underwent corneal neurotization, which unfortunately failed, and now she's stuck wearing a bandage contact lens because we could not get a scleral lens to center on the eye with such irregular conjunctival tissue following corneal neurotization surgery. So as a lot of our presenters have indicated, utilization of a number of therapies is probably a very good plan, and to the extent that we can all work together and make sure that we get the best outcomes for the patient, it's very helpful. Thank you so much.